Sorry. Halo,
Halo, Dr. Hans. Good to see
hai,
you again. Selamat siang, Prof. Lis, Dr. Retno, Dr. Suci. Selamat siang, Dr. Hans. How are you
selamat
today?
siang. Mama, I'm fine, I'm fine.
Good to see you again.
Selamat siang. Nice to meet you,
Thank you, nice to meet you
Hans.
too. Hello.
Dr. Hans, could
Yeah,
you hear my voice?
I can hear you, yes.
Okay, thank you.
Assalamualaikum warahmatullahi wabarakatuh. Shalom Om Swastiastu, Namo Buddhaya, Salam Kebajikan, Rahayu. Let us praise and give our utmost gratitude to Allah Subhanahu wa Ta'ala for His mercy and blessings we could gather in this very special occasion. Good afternoon and welcome our speaker, Hans Vrielink, MD PhD, Consultant Transfusion Medicine, Senior Consultant Apharesis, Consultant Donor Medicine, Senior Scientist for Apharesis Research, Senior Consultant Sanquist Consulting Services, Sanquist Blood Supply Foundation, the Netherlands, President of World Apharesis Association. Dr. Nyoman Suciwidyasiti, Magister of Health, Clinical Pathologist, Consultant of Hematology and Immunology, Head of Clinical Pathology Residency Education Program, Faculty of Medicine, Universitas Diponegoro, Semarang. Dr. Dwi Ratnaningrum, Clinical Pathologist, Consultant of Infectious Diseases, Head of Clinical Pathology Department, Faculty of Medicine, Universitas Diponegoro, Semarang. Dr. Rahayu Nindhita, Clinical Pathologist, Teaching Staff Faculty of Medicine, Universitas Diponegoro Semarang, as well as the moderator of today's guest lecture. Our respected professors, attending doctors and fellow residents, and all the audience, thank you for coming here today. Welcome to guest lecture of Clinical Pathology, Faculty of Medicine, Universitas Diponegoro Semarang. Antibody testing in the patient. Could this substitute pre-transfusion testing? Screening and identification of antibodies are procedures that detect and identify antibodies in the patient's blood. These procedures are often performed before blood transfusion or surgeries. So, it is very important for us to improve our knowledge about screening and identification of antibodies as pre-transfusion testing. We hope that this event can provide a new insight and knowledge in the implementation of screening and identification of antibodies in the future. To begin with, let's start with sending our prayers. Prayer begins. Finished. Before we proceed to the main event, I would like to inform you about our agendas today. First, opening speech from Dr. Dwi Ratnaningrum, Clinical Pathologist, Consultant of Infectious Diseases, Head of Clinical Pathology Department, Faculty of Medicine, Universitas Diponegoro, Semarang. Lecture from Hans Vrielink, MD PhD, about antibody testing in the patient. Could this substitute pre-transfusion testing? Moderated by Dr. Rahayu Nindhita, Clinical Pathologist. Discussion, photo session, and closing statement. The participants of this lecture will be given a certificate by filling the required data on the attendance link in the chat section. The first attendance link is now open. The second will be opened at the end of the discussion. The next agenda is opening speech from Dr. Dwiradhaningrum, clinical pathologist, consultant of infectious diseases, head of clinical pathology department, Faculty of Medicine, Universitas Diponegoro, Semarang. To the Honorable Dr. Retno, the time is yours.
Thank you, Dr. Nindhita. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. The Honorable Hans Vrielink, MD, PhD, Consultant Transfusion Medicine, Senior Consultant Apharesis, Consultant Donor Medicine, Senior Scientist for Apharesis Research, Senior Consultant Semen Consulting Services, Semen Blood Supply Foundation, the Netherlands, and President of World Apharesis Association. The Honorable Dr. Nyoman Suci Widyastiti, Magisters of Science, Clinical Pathologist, Hematology and Immunology Consultant, Head of Clinical Pathology Residency Education Program, Faculty of Medicine, Universitas Diponegoro, Semarang. And the Honorable Dr. Rahayu Nindhita, Clinical Pathologist, as the moderator of today's guest lecture. Our respected professors, attending doctors, residents, and all participants, thank you for joining this event today. Alhamdulillah, thanks to Allah Subhanahu wa Ta'ala, so that this afternoon we could join here in this special occasion, virtual guest lecture of clinical pathology, Faculty of Medicine, Universitas Diponegoro, Semarang, with the title Antibody Testing in Patient. Could this substitute the pre-transfusion testing? On behalf of Clinical Pathology Residency Educational Program, Universitas Diponegoro, Semarang, I'm privileged, deeply honored. Thank you to welcome our special guest lecturer, Hans Vrielink, MD, PhD. We would like to express our heartfelt and highly appreciation for accepting our guest lecture invitation. This is the first international guest lecture this year. The previous was held in November 2024 with Prof. Silvalil bin Alwi from Malaysia. From this occasion, we intend to develop our students' quality and knowledge. To our participants, thank you for joining this program and have an enjoyable and interesting guest lecture. Yes, the end. Wassalamualaikum warahmatullahi wabarakatuh. Now we return the screen to Dr. Nindhita to continue with the program. Thank you.
Thanks to Dr. Dwiradhaningrum, clinical pathologist, consultant of infectious diseases. To all participants, please fill in the attendance link which can be accessed in the meeting chat. Ladies and gentlemen, the next agenda will be led by Dr. Rahayu Nindhita, clinical pathologist. Allow me to present her curriculum vitae. Dr. Rahayu Nindhita, clinical pathologist. She graduated from clinical pathology at Faculty of Medicine, Universitas Diponegoro in 2017. She recently working as clinical pathologist at Dr. Karyadi Central General Hospital. To the Honorable Dr. Rahayu Nindhita, the time is yours.
Okay, thank you, Dr. Nindhita. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, professors, doctors, and seniors. Welcome to our annual guest lecture series. And please allow me to be moderator today. And now, has joined with us our speaker from Netherlands. Please welcome Dr. Hans Vrielink, MD, PhD. How are you today, Dr. Hans? Good afternoon, Dr. Hans.
Selamat siang to all of you. It could be a little bit noisy here because I'm just like Dr. Lieke, I'm at a conference in Yogyakarta, and it could be a little bit noisy, but we try to avoid that.
Thank you, Doctor. We are grateful to have you join us here. It's an honor for us to be able to join your lecture for the umpteenth time. Thank you very much, Dr. Hans. And now, before you started the presentation, please allow me to read your curriculum vitae. Dr. Hans' education history, a lot of and many experience from him, and now he active in as president in World Apharesis Association. Yes, and work experience the transfusion and apharesis medicine specialist of unit of transfusion medicine of Sanquist blood supply, senior consultant of apharesis department of the unit of transfusion medicine of Sanquist blood supply, senior consultants of the department of Sanquist consulting services, and international JC and fact inspector. And now moving along to our main session, today we will hear lecture by Dr. Hans about antibody testing in the patient. Could this substitute pre-tranfusion testing? Please, Dr. Hans, the time is yours.
Yes, I tried to share my screen, but you can see my presentation when it's working.
Yes, maybe you can slideshow.
Yep. Now it's slideshow.
Okay.
Okay, I make this small. Okay, so thank you for the invitation. It's a little bit weird. I'm only a few hours driving from you at this moment, but yeah, there was no time to come over to Semarang. I'm in Yogyakarta, as I told you. So, first of all, I have no conflicts of interest to disclose. So when you look at the title as pre-transfusion testing, what you mean then with that is that everybody is needing blood. Every country is needing blood. In many countries, it's of course of the maternity, so the delivery of a baby or surgery, but also trauma and also disasters can be the need of blood. And when we, as doctors working in the transfusion world, talk about blood, we talk about, of course, about safe blood. So, and safe blood should be, of course, for our donors and for our patients. So when you see this, and I hope you can see my my arrow moving over the screen, what you see is that there is a responsibility for the blood establishment in the safety of the donor blood. And what you do see also is, first of all, the donor questionnaire. That's one of the cornerstones in this world. Besides that, of course, also think for the transfusion transmittable diseases. And other things, what you see is patients, and the hospital is responsible for the safety of the patient according to the blood transfusion. And that's not only the test what is done, the compatibility test, but it's also avoiding that unnecessary blood is given, and that's called blood management. So when we talk about compatibility tests, we talk about the pre-transfusion testing. So we need in this we have a patient and a donor, and this patient blood or the donor blood should be compatible to the donor. Why? So what is being done is, of course, for this to be safe, is the blood separation and the blood collection, and especially what is important for the pre-transfusion testing is already the blood type of the donor. And the blood establishment is also responsible for that. So responsible that the correct label is placed on the correct blood unit, and that the blood transfusion, the blood typing is correct. On the other hand, the hospital is responsible for the indication of the blood transfusion, but also of a correct typing of the patient's blood type. But don't forget, the hospital is also responsible for the blood typing of the donor. And of course, besides that, to test for compatibility. And I will come back to these things. But why do we want compatibility? So what you see on the right side of the screen is, this is a normal picture what you would see in the blood. But when you mix wrong blood to each other, you get an aggregation, and that's what you want to avoid. And this was already seen about 130 years ago by Karl Landsteiner in Austria, in Vienna, in Europe. And what you do see is he mixed blood from himself with his colleagues, with blood of the colleagues. And he noticed that in sometimes the blood was, sometimes nothing was aggregating. And it's exactly the same what has been shown in the previous field. So with that, he detected, in fact, the A and the B and the C blood type. And the C blood type was, after a few years, renamed to the O blood type, or in fact, to the 0 blood type. And 0 is more reflecting to the anti-A and the anti-B. In fact, what Dr. Landsteiner detected was the anti-A and the anti-B. So what we will see when we mix blood type A with an anti-A, you will see an agglutination, so a clotting of the red cells in the bloodstream. But besides that, because of the activation of the complement system, you also see an hemolysis because the red cell is breaking apart. And this is something what we don't want to see in our bloodstream or in the patient's bloodstream, because this is a really dangerous situation. So anti-A and anti-B, these are predominantly IgM antibodies. And there is a difference between the IgM and the IgG antibodies, which is the other antibody which is important in blood transfusion. So the IgM antibodies are created, made following exposure to an environmental substance. They're also called naturally occurring. And as you remember, anti-A and anti-B is formed sometimes even before the birth, but usually within the first 3 to 6 months of the child's life. And the other thing is, for the anti-A and the anti-B, what is known, they are potent hemolysins, and which is meaning with that they are capable of causing intravascular hemolysis by binding of the complement, as said before. IgG, on the other hand, you have also an anti-A and an anti-B and IgG. They develop possibly after a blood transfusion, so they are not naturally occurring, but in fact fall under the definition of an irregular antibody. So, as said, you get with an anti-A and an anti-B, they bind to red blood cells with an other antigen than is meant, and with that they activate the complement cascade. And together with that, you get an aggregation and an intravascular hemolysis. So let's focus a little bit on the red cell. what you see is that red cells are oval and flexible biconcave discs without a nucleus and organelles. But surrounding of the of the red cell, we have a membrane which is composed of proteins and lipids, and the function is via our hemoglobin protein, the oxygen transport. So no nucleus and no organelles. In other words, it's a sack of hemoglobin. More is nothing. But why do they have these all these reactions? And when you look at that, you must realize that we should go to the membrane of the red cell. And when I go more into detail in this membrane, what I do see is, and what you do see is, I try to point out, this is the outside, this is the inside of the red cell. And on the outside, you see all kinds of materials sticking out. And all these are our blood types. So you have lipids going through, you have other materials, sugars on this. You see that going completely through, and some even go from inside to outside to inside to outside, and having more things. You see here, for instance, which is one of the examples of the rhesus blood type. We have a lot, and one of the questions I always mention when I am in a group, can you tell me how many blood groups you have? Now, this is really difficult to answer because it's increasing very often, but at this moment, and this was the data from October 2024, we have 47 blood group systems and more than 380 antigens. And luckily, we don't need to type them all and to check them all, because this is really impossible. We have to take care of about 20 antigens, which are of importance for our daily practice in the blood transfusion world. The most easiest one in that way is the ABO blood type. And the ABO blood type is nothing else than 5 sugars. As you can see, we have 5 sugars in the chain, and without any additional sugars, this is the blood type O, in other words, the H antigen only. When there is a NAGA sugar, which is an N-acetyl galactosamine, then you have the blood type A. And when you have a galactose on the same place, you have the blood type B. And these sugar structures are very normal in the world, in the environment. And with that, we come also into contact with those sugars and make an antibody to the antigen we don't have. And so that's the background. Then we have much more, of course, the rhesus systems with the CEs and Cal, and then the Cal, of course. And Cal is also, think of the big K, the small K, the KPA, the KPB, etc., etc. The Duffy blood system, the KITS, usually is written as the JKA, JKB, M&S system, Lutherans, and many, 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 many others. So blood types, as said, are nothing else than extinctions on the, and they can be from proteins, carbohydrates, glycoproteins, and glycolipids. And keeping this in mind, what you do see is these are named the antigens. And an antigen in that way in immunology is nothing else than a substance which could evoke an immune response. For instance, the production of antibodies. So could evoke, not always. So yes, we have some antibodies always, and that's what in the ABO system. And so you make always an antibody against the antigen you don't have. So when you have a blood type A, you don't have the B, and you make an anti-A. Sorry, an anti-B, of course. And when you have the blood type B, you don't have the A and make an anti-A. When you have blood type AB, you have both, and you don't make anything. And when you have blood type O, then you make them both, because you fail to have A and B. They are always present, natural or regular antibodies. Against the others, you must come into contact. And when you come in contact, you can make an antibody. And so usually we name them irregular antibodies. And all of these are usually IgMs or IgGs. So why do they develop? Why do we have red cell antibodies? So they can develop naturally, like in the anti-A and anti-B. They are in our environment, in our food, bacteria, etc. On the other hand, when we get a blood transfusion, and note that more than 100 microliters of red cells, and that's only 10 to the 9th, is already capable in making an antibody reaction. Another thing is, of course, pregnancy. And pregnancy, we know now that during every pregnancy, blood is going from mother to the child and from the child to the mother. That's always. And that's not only during the delivery, but also during pregnancy itself. But we can also have antibodies due to exposure to some viruses or bacteria. But these can also change some of the blood types. And what is failing on my slide is organ transplants. And also in organ transplants, you can develop antibodies. So IgM antibodies, as said before, they usually are developed following exposure to environmental substances. So they are naturally occurring. Generally, they are cold antibodies. They're not reactive at our body temperature, but there is a little clinical significance then. So when they are active at 20 degrees Celsius, they are rather not dangerous. We have exceptions. Anti-A and anti-B are very potent to do this also at 37 degrees Celsius. So because why, I would say, these anti-A and anti-B have very active hemolysins, and they cause an intravascular hemolysis by binding this complement, which is significantly, clinically significant. We are really, really afraid to give a bag of A to a person who is having blood type B. IgGs, following all exposure to foreign RBC, to foreign red blood cell antigens, and are usually active at 37 degrees Celsius. So when doing a blood transfusion, IgGs can be developed based on the blood transfusion. And we should also note that IgGs can cross the placenta, so are important in the development of the hemolytic disease of the fetals and the newborn. IgMs, on the contrary, not. I'm sorry. So the competition, how do we do this? There are methods to detect. We have, of course, what you all know is the major ABO incompatibility. And what you do see is that we do this with the immediate spin or saline cross match. So we mix with that red cells from the donor with serum of the patient and see whether there is a direct clotting. And what you do see is that red cells have an electronic layer around them, and this is making that they separate a little bit apart from each other. They don't clot naturally. However, the IgM can mix that, but the IgG, which is much smaller, can't pass this distance. So when you have an IgG, you will never have a reaction in this immediate spin cross match. But the IgMs can, and usually these are called antibodies, like an Marie blood type, or a Nico, or a Simon, or a P, or a Lewis, or a Lutheran, or whatever. And this can have also when you do a blood type testing in the normal way, because you do this at 20 degrees, that you can be confused finding an antibody like that in your test, but this is not always likely. Compatibility testing. So what you need to do is that ABO compatibility, A and B, should be separated from each other. So we need to have a compatible donor with a compatible patient. But you mean we need also to be aware that antibodies in the serum or in the plasma of the patient can be already detected at red blood cells from the donor. So in previous transfusions, it can be developed antibodies against the new donor already. So we need to find that. So in a way, so as said, what we do is we mix serum of the patient with red cells of the donor, and we look at them whether they clot. And it's irrespective whether we do this on cards, or we do this in tubes, or we do this in gel cards, in the gel prop. So this is always all in the same system. But what you do see is that, as said, we can detect the IgM. So the anti-A and the anti-B can be detected, but the others can't. So when we mix that, we need to have a more detailed way of testing. So here you see such a card, and what you see is a positive reaction. So in that case, you don't have that the cells are going down, or a negative reaction when everything is going down. And what you want to do is, when it's an IgG, you don't see anything. You see a negative result. So you think, oh, it's safe, but that is really not true, because they can't stick together. And for this, we need a small trick, and we name this the indirect antiglobulin test. So I will explain a little bit of that. What you do is you mix, like in the other tests, you mix the serum of the patient with red cells of the donor sample, the bag of blood from the donor. So this is the coming from, not from the bag itself, but from one of the crossmatch segments. Of course, you let it incubate, so the IgGs, when they are present in the serum of the patient, can stick to the red cell itself. But now there comes a trick. You let an animal, you usually let make an anti-human IgG. And this is what you add to this system already. So, and again, let it incubate. And with that, by binding them, the IgGs from the patient to the IgG of the goat or the mouse or the rabbit or whatever is being used in this way, and then you see the clotting. So IgGs need to be detected, can only be detected in this way with an additional test, which is called the indirect antiglobulin test. So we do compatibility testing. We do, in other words, cross-matching. And what we should find is that all is negative in our tests. So this meaning also, when you find something positive, that you need to repeat it and repeat it, or take new bags or whatever. And if possible, you do an identification of the antibody or the antibodies and select units from red cell antigen negative donors. Or you should perform compatibility tests until you find a negative unit. And when you have, for instance, an anti-small e, you have to find, and you need 4 units of blood, you have to do at least 100 cross matches to find 4 negative. So this can be a lot of work, but also it can be having a lot of time and sometimes there is no time for the patient. So why shouldn't we test the antibodies in the patient then? So, and in other words, this is also named the type and screen technology, which is being performed, amongst others, in my country, in Belanda, but also in many Western world countries. So, going to the incompatibility in whatever. So, type and screen means I test the blood type of the patient, I test the blood type of the donor, and I screen whether there are antibodies. So again, test the blood type of the patient, test the blood type of the donor, test and screen the patient for irregular antibodies. So what should you do in the hospital laboratory is the typing. You determine very easy the blood type of the donor and the patient. This is only 10 minutes. Then again, the donor, and this can be done by really typing. And when you have done that, you can have also an immediate spin cross match to check or do this. And this is only a few minutes also, whether these 2 units are compatible in ABO. So the IgM is really easy to find out in this, the anti-A and the anti-B. But for the remainder, what you do have to do is a type and screen. So this is what you need to do then in this case. Are there antibodies for, that should not be in the patient against red cell antigens for donors? So what you do is you take a commercially available panel. They have 2 or 3 different cells from specifically selected donors, always blood type O. And these antigens, they should be relevant for the transfusion, and they should be homozygous or heterozygous present on the red cell. So you see here, I'm not going to name them all. You see them on the screen. What should be mandatory, but not compensatory is the right A, for instance, the Lutrin A, the CW, and the KPA. But they don't give so much problems. They are many, when transfused, wrongly transfused with antibodies, they have severe hemolytic reactions, but these are rather rare in a normal patient. Then you do, in fact, the indirect antiglobulin test, so the Coombs test, with serum of the patient and cells of these donors. And these donors these panels are delivered with specific forms. And based on the forms where you see what the reaction could be, you can have detection of the potential antibody present. So why should you do this? What you do see is that when you do such a test, the validity of this test, of this result, is 3 months in a male non-transfused donor or in a female non-transfused donor patient, of course, non-transfused patient, which when she was at least 3 months not pregnant. So 3 months validity. And when there was a blood transfusion in the recent history or pregnancy, the test is valid for 72 hours. This is meaning you can buy time. So do on Friday the test for a surgery on Monday. So this is making it a little bit easy. So when then blood is needed, acutely needed, you check again the blood type of the patient and the donor very quickly. This may be when you did this before already in the computers, it's named the electronic cross match, or you can do the immediate spin cross match. So after 10 to 15 minutes, the bag of blood is already ready and cross-matched and ready for transfusion. So in other words, very quickly available, almost immediately available when the blood is needed. So no additional tests need to be performed anymore. So when it's positive, then you get, so the type and screen in one of the donor positive panels is positive. Then and it's really, really with high percentage, you can say then that there is an antibody. So then you need to identify, or is a possibility to identify the antibody which is present in the patient with other test panels and find a compatible donor selection. But that's a trick, because with that you don't have you need a very large pool of donors, and I come back to that. What you also can do is more do a lot of cross matching based on what you think you find, and find a cross match, a negative cross match. But you have 72 hours time for that, as said, and not the surgeon is not calling you every 10 minutes from the OR. Where's the blood? I need the blood. Whatever you want. So this can take hours to find, and your patient can be dead at that moment because he bled to death. So as said, you need a compatible donor selection. But with that, you have to talk with UDD PME that you have an extensively phenotyped or genotyped, that's also possible, donor pool needed. And a large donor pool and is thousands of donors, because you have an enormous variability, of course. So finding negative blood with cross matches, that can take hours, as said, but you need to know then what you have in your population in that way. So you need also to know, and that's something I really think that you should know, is that an antigen and an antibody are not equal to each other, and not in way, not even the anti-D or the anti-small c is equal to each other, of course, because the D factor is enormous, getting antibodies. In what way? I'm a little bit disturbed, I'm sorry. But so the immunogenicity of the antigens is different. So when I transfuse to a D negative person, I transfuse a D positive unit, I have 80% chance to make antibodies. Now that's not that difficult in Indonesia, because you're anti-D, your D negative persons are very low in percentage. So that's not the problem in Indonesia. But another thing is, so 80% for the making anti-D, and anti-Cal is really also the same in 5%. So in 5 of 100 transfusions, this goes wrong. The anti-small c in 2%, the big E in 1.7%, small e in 0.5%, and the big C in 0.1, 1 in 1,000. So the others are 1 in 10,000 or what even less. So the possibility when you have antibodies in your, you find antibodies in your patient population with type and screen, you must think of these 6, in fact. So this is usually, so you catch already 95% of your antibodies with these 6 antigens. So we need to find a way, I'm sorry. We need to find a way and we need to understand from each other that we have differences in the antigens in your own population. So you need to know your own population. I can't compare. Look at for instance, at the Miltenberger A, which is the lowest here on the screen. Miltenberger A is for me in the Netherlands. It's very, very, very low. But for you, could be a problem. It's 15%. And others, what you do see is Caucasians, where we come from, it's a D factor is present in 85%. So 15, 16% is D negative. So there's the possibility that somebody gets a positive unit when it's negative is really large. But in Asians, it's 99 to 99.5%. Also, the Cal is different in what way? So know your population, know what frequencies of antigens are present in your own population. So in Indonesia, these are data from Indonesia. What you do see is that the D, so 2 in 1,000 are D negative, and that's why you have so less D negative donors. So you can see here also, important to understand is also that it's always thought that the Cal factor antigen, so the big K, which is seen here, is very rare, and they say even 100% is Cal negative, but this is not true. We did in September, we did in Yogyakarta a small survey, and we found positive. And Dr. Ria, for the previous manager, medical responsible from UDD Pusat PMI in Yogyakarta, in Jakarta, found several Cal positive donors, meaning that an anti-Cal can be developed in the patients. What you have further is you must know that what is I'm sorry. Can you please, I'm trying to give a lesson here. What you do see is that some of the antibodies give very severe reactions, but also some of them are passing by through via the placenta, giving reactions in the baby or in the unborn even. So we need to take care of that. We need to know of that. Besides that, we need also to know what is our composition and what is how our phenotyping of the rhesus system, the C's and the E's and the D's. So what you do see is that the big C is much more prevalent than the small c in that way. And you see, this is really the population of Indonesia, what you see here. So looking at this and looking at the one of the previous slides, you can imagine that when you have so many small e's negatives, that in 0.5% of your population, a small e can be developed an antibody in one way. And then you must find also that different ways of which donor population, and what is then the possibility to find a compatible donor. And I go into that a little bit. What you do see, I mentioned that when you have an anti-small big E, which is very common in Indonesia, what you do see is then that all the people with double small e could donate for this person, and that's a high percentage, around 70%. So finding an anti-big E, what you do see is that you can use then donors that have this phenotyping. So phenotyping in the donor is one of the most important things to start with, in my opinion. Then you find in 7 of the 10 red blood cells that are compatible in the cross match, 3 not. So when you need 3 units very quickly, you have to start with 5 or 6 units to cross match to find at least 3 or 4 negative units. An anti-E and the combination with a small c, then you come in 50%. So in 5 of the 10. So when you need, in this, with these kind of calculations, you can also see that using taking 3 units when you need 3 units for cross matching is wasting time. So you need to take more units, more donors need to come in also, need to be there. And as said, when you find an anti-small e and you have 4 units needed, you need to do 1/100 of cross matches, which is very, very, very time consuming, and of course also very costly in this way. But the advantage from the type of a type and screen is that these cross matches can be done up to 72 hours prior to the surgery, for instance. So your surgery should not be, it's not needed to be delayed in this way as much as was thinking. And you don't have problems with surgeon or anesthesiologist that is calling you every time again for release this product, please, because my patient is bleeding to death. So in answering the initial question, the initial thing in this way, and so answering is, could the substitute, or in another way, let's rephrase it, antibody testing in the patient, is this a substitute for pre-transfusion testing? The answer is very clearly yes. So it buys you time. And maybe you think it's really costly, but time, also doing many cross matches and losing, despite that, also losing a patient because of bleeding to death, because there is incompatible blood available, is less big. So we have, and coming to a conclusion then, that type and screen, or so the antibody screening in the patient is indeed a substitute of the pre-transfusion testing. This is making a patient happy, and the death will going away from this patient, at least due to the transfusion. So with that, I would like to end my presentation, and I give back the word to Dr. Lieke, and I will end the sharing. And
okay, applause for Dr. Hartz. Thank you, Dr. Hans, for the interesting lecture. And now moving along to our discussion sessions, are there any question in chat column? Maybe if there
So,
are,
Lieke, it's not needed to place them in.
hello?
Yeah.
Question number 1 for the Dr. Hans, from the Dr. Gita, clinical pathologist resident. Dr. Hans, how do healthcare professionals decide which tests to use before a transfusion?
Usually this is done, it's a really good question. This is usually done in combination, so in collaboration with an organization like PMI or the blood establishment of the hospital in that way. I think it should be bigger. It should be more a very large region who is doing this because you need to rely on more blood establishments because of the number of donors. So when you would decide to do this, you must talk, of course, with the surgeons and the internal medicine doctors, but also the laboratory. So the pathologists are responsible for this, and talk with PMI UDD, UDD PMI, because that would be the best. So meaning also that there must be money for that. And since this is saving lives and saving time and saving anyway, also doing centrally the antibody testing, this could less costly for the Ministry of Health. So there must be a good balance in the costs. So there must be, in my eyes, there should be uh, um, uh, a request or confirmation from organizations like the pathology, the hematology, but also the UDD in together and make a good financial balance for the Ministry of Health, so the Ministry of Health could decide to do this.
Okay, thank you, Dr. Hans. Maybe Dr. Gita, is it acceptable? Maybe.
Thank you, Dr. Hans,
Okay, thank
for
you.
the information.
You're welcome.
And second question, maybe from Dr. Fixie, clinical pathology resident. For Dr. Hans, how does antibody testing impact transfusion in patients with specific medical conditions, such as autoimmune disorder or cancer? How about you, Dr. Hans?
In fact, these patients need to be transfused. So autoimmune hemolytic disease is really difficult to transfuse. You should avoid transfusions, but this is really a challenge. So sometimes you see an anti-big E in an auto antibody, and then you need to find a good donor. But this is really difficult. So preferably you would like to have then a big E negative person, but this is really difficult again because you have the possibility also to develop an anti-small e in that way. So these kind of things you need to consider enormously. So this can impact transfusions, yes, in a way. The direct transfusion will be involved, of course, and will be influenced. But in time, you see that in the future, the patient will be not more difficult to transfuse, but likely in the same way to be transfused. So development of an anti-big E and an anti-small E, so the outer big E with an allo small E, this is really difficult to handle and needs a lot of IgG. In cancer, you don't need so much transfusions in cancer. So when it's a solid tumor and you want to remove, you need to remove. You know this in the forehand, and that's not a problem at all. In leukemia also, so the lymphomas and leukemias, what you do know is that sometimes the antigen expression will differ a little bit, but for the remainder, you have time to find, but you have always a maximum of 72 hours in these kind of patients. So in 72 hours, you need to try to find the most compatible product.
So significantly significantly, Dr. Hans.
Yeah. For sure, it can have significant implications on the donor, but it makes it should make it safer for the patient. It should make it safer.
Okay, thank you. How about Dr. Fixie? Is it acceptable?
Yeah, thank you so much, Dr. Hans, for the explanation.
Okay. And next question, maybe. I see a raised hand from Dr. Rima. Maybe you will ask to Dr. Hans directly, maybe. Oh, okay. Question number 3 from Dr. Monique, clinical pathology resident. Dr. Hans, what is the role of antibody testing in the patient care, and how is it currently utilized?
What I think that in I spoke this morning about this in with Dr. Tegur Triono here in he is pathologist in the Dr. Sajito Hospital in Yogyakarta, and he is testing already also for antibodies in the patients in that way to make it easier. So at this moment the role of antibody testing in the patient is in Indonesia, then I would say this is really low. But what you need to remember also is that the level of antibodies, especially for a kit antibody, for instance, is not stable. So you can test and you can find negative results, but also negative cross matches. And there is potentially an anti-kit A or an anti-kit B, and that these are frequently the cause of the delayed transfusion reaction. So at this moment, the role in Indonesia, I think, of antibody testing is very low, but this is also due to that when you find it, how to act with it, because your donor population is also not typed. But this is worked on in Jakarta, what I know, and there are some donors, a few thousand, 8 to 10,000 or so are typed at this moment in Jakarta. So the role is very small at this moment still.
Okay. How about Dr. Monique? About this? Is it acceptable?
Acceptable. Thank you. Thank you, doctor.
Okay. Any participant raise hand, maybe? Or more question in chat column? From Dr. Lia, clinical pathology resident. Dr. Hans, can antibody testing alone ensure compatibility between donor and recipient blood types?
No. As said, it's an additional. A kit can't be found after 3, 4, 5 months, so it can be gone. But also it's not. It's not completely sure that you will not develop new antibodies. But what you do see is that when you do an antibody testing and you follow the rules of the type and screen with donor typing, you make it easier for the lab and at least as safe as a negative cross match. The negative cross match could be a little bit in favor because it's this unit you test, but you never know what's going to happen. So these kind of things, that's really tricky, but it's really acceptable in the that it's not decreasing the safety of a blood transfusion. It's making it especially for the lab, but also for the patient itself, a little bit more safer.
Okay, very clearly, Dr. Lia.
Thank you, Dr. Hans.
You're welcome.
Okay.
Sama-sama.
Maybe any question in this chat column? Okay. Next question, Dr. Hans. The first, how applicable are antibody testing to be done in small hospitals and remotely located health facility? And second, if we want to implement type and screen protocol for cross-match substitutions, do we need to have a central database of antibody testing? How about you, Dr. Hans?
Two very, very good questions. How applicable are the antibody testing in small hospitals? They are okay, but depending, of course, on how much donors you have. So small hospitals in faraway islands, for instance, rely still a lot on replacement of family donors or on. So you can't fly in. It's really difficult to fly in from the from the UDD PMI to every small island where there is a very small hospital and there is a trauma patient coming in, then you lose time in that way. So then it's really not possible in that way. But when the small hospital is getting blood from a central organization, it is very feasible. That's so. Yeah, I need to realize always that geography is in Indonesia different than in even geography in Indonesia. Part of Indonesia is different compared to Java, the island of Java, for instance. So these we need to keep in mind. The second thing is, do we want a central database of antibody testing? I answered this always with for Indonesia in a two-letter answer, which is starting with an I and ending with an A. Yeah, of course, with big capitals. A central database of antibodies found in patients is making it much more safe. You have the privacy regulation. So when a patient is shopping, and you do see this in Indonesia, patients are shopping between hospitals because of the costs they have, and they have to bear sometimes the cost for themselves. So they go to other hospitals, and they make it then much more safer for themselves when hospitals have the capability for a central database of the antibodies found in specific patients. But this need to be reliable, of course. But yes, this is future, and I can't. I imagine that this is really important also in Indonesia, that you have a central database in which of course, the patient should have given permission for that.
Okay, how about you, Dr. Brian? It's clearly. Next question, maybe if any else question in chat column. Okay. Next question from Dr. Dewi, clinical pathology resident, for Dr. Hans. In the remote health facilities with limited facilities, is there any test that can be done to anticipate the presence of irregular antibodies in donor samples? Is type and screen only enough? Maybe this question almost the same with the question before.
Yeah, but
Yeah.
there's something nice in that, and I want to come back to that also. What you see here is, I think, what is meant is patient samples, but donor samples. Donors are also human beings, and some donors are also patients in the past and have had blood transfusions, so can have irregular antibodies. This is really important, and that's why everybody here in Indonesia is always doing the major cross match, the minor cross match. We never do a minor cross match, so we never cross match the serum of a donor with the cells of the patient. Why? The blood transfusion service is doing this once. So when a donor is coming 100 times, he should or she should not be tested for 100 times. This is also costly. This costs money and time from the laboratories in the hospitals. So also from this, there should be a business case made to test donors for irregular antibodies and to be known of that. I'm really not afraid for irregular antibodies in a donor, because when you check this, and the only thing is when I would be afraid, it maybe a little bit more is in whole blood transfusions, but this is not common more in Java, for instance, but it could be common still in the very small islands where the donor is coming in because there is no equipment available. But when you do have a separation of your blood, the hematocrit is already of 70 to 90%. So let's say around 80%. So there is almost no plasma anymore in this product. And you add also 100 mils or of storage solution to the so the food for the red cell to the product to make it a good product for the patient. So the antibody level in the patient in the donor is very, very low and not of any use by giving this to the patient, because what is the 10 or 20 mils in the product giving to an adult having a total plasma volume of 2 or 3 liters? So this is nothing. So this will be diluted enormously. So I'm not afraid of that so much. So this could avoid a lot of work also in laboratories in getting rid of the minor cross matches in platelets, plasma, red cells, etc., etc. So yes, in health facilities, also with limited facilities, you can do the 2 or the 3 cells panels. The technique is exactly the same in the as you do now in the standard cross match, and you buy time also here. So I think this is an answer.
Okay. How about this, Dr. Dewi? Clearly, okay.
Okay, clear. Thank you, sir.
You're welcome. Sama-sama.
Any question in this chat room? Okay. From Dr. Nina, clinical pathology resident. What is your advice on antibody testing in patients
Okay, in
who
the
receive repeat
thalassemia patients,
transfusions?
so the multi-transfused. Yeah, so the multi-transfused, the beta
Yes,
thal,
multi-transfused
yeah,
patient.
the beta thal, that are transfusion dependent. Dr. Leaker knows my answer already. As you have the top 6, the top 6 is besides the cal all a rhesus antibody in the rhesus system. So that's 6. So the advice is to phenotype your thalassemia patients in avoiding to develop more antibodies. So phenotyping in your patients and then phenotype compatible products in giving, that's one of the solutions that you should do as soon as possible. Another thing is also leukodepletion in this. We know that in leuko non-depleted products, the development is a little bit higher and of development of antibodies is a little bit higher. So another thing is that a substantial part of the thalassemia patients is having already antibodies. So also for this is it's making it more and more difficult to find a compatible donor product. So yes, I would do this as soon as possible, and yeah, what you should could do in fact is yeah, making also in this buying time for the patient. So you have an appointment for transfusion on Wednesday, then you can start on Sunday already with finding the correct donor. But you need to repeat every transfusion episode again.
Okay. This is for multi-transfuse example in hemodialysis patient and
yeah, especially the multi-transfuse.
multipara woman, yeah. Okay.
Yeah. But now not only a multipara woman, I would say because as said, the top 6 is rhesus, CE, D, and the cal. That's the top 6 possibility to develop antibodies. You can develop antibodies already in your first pregnancy. So and whatever is more is they are dangerous, can be dangerous for the baby. So females in the childbearing age should be transfused phenotype and Cal compatible.
Okay, thank you, Dr. Hans. Is it acceptable, Dr. Nina?
Yes, thank you, Mr. Hans.
You're welcome.
Maybe any question in chat room? Okay. There's no any question again. Okay. Maybe this is a chance for me to ask you, Dr. Hans. I have two questions, two cases. And first, an accident patient prepare for operation, and second patient is thalassemia patient. But both have the same result of cross-match test, are positive major for 3 units PRC and negative control, negative autocontrol and negative direct cum test. But we don't have to do minor cross-match because we have to screening antibody in donor. My question are, first, is there an IgM antibodies in both? And second, what we should do, and which the component can be safe to transfuse, or we choose, Dr. Hans. Thank you.
So I to make it really clear, you have an important which patient is. You have a pre-operative a patient who needs to be to get surgery, and pre-operative you find they need 3 units, and they find all 3 major positive in the tests, with a negative out of control and a negative direct cum. So there is no autoantibody, and there is also no detection of IgG on the red cell. When you have, this is in the normal standard cross match, or in the, or in so your first question was on IgM. The major cross, so the major cross match can be positive for the IgM, but this is the direct spin already, the immediate spin, and it could be an IgG also. But why it's positive in all the 3 units must be a very so there can be one to a high frequency antigen, an antibody against the free high frequency antigen, but it can also be that you see in this case what was in my mind. So high frequency of I forgot what I want to say. Anyway, it's very weird to find this. Yeah, I know already. There could be also multiple antibodies. So in case you have made already an antibody, the possibility to make new antibodies or more antibodies is rather large. So it could be multiple antibodies, or an antibody against a high frequency antigen. So what to do is identification. Always, what I would say is identification, and make a good lab where you can send these samples to identify. When it's multiple antibodies, it's really almost impossible to find a good compatible donor in this situation. When it's a private antigen, so the patient itself has a private antigen, so it's having a very low frequency something, I would go to the family in that way. So because usually this is a family matter. So when positive in all three ways, I would check for, is it multiple in all three units tested? I would check whether it's multiple antibodies. I would go to find out what antibodies these are, and for the remainder, when it's a high frequent, I would ask family members to donate blood. So direct family members, brothers, sisters, in that way. First, of course, not directly take blood, but cross-match first, whether this is negative or not.
So, what
But
do you think?
the IgM relation, I would see yes.
Can be safe? Which component?
Sorry? Which component can be safe? Yes. When there are no autoantibodies, none of the components can be safe.
Okay.
So it could be also, but the direct is negative, so auto antibodies is not that good idea. But when you need to transfuse in a thalassemia or in pre-surgery, I would say to the surgeon, okay, I'm sorry, I don't have blood compatible at this moment. We need to find out first. And when the surgery needs to go on, you don't have blood, because when you transfuse something, you probably will have problems with hemolytic transfusion reactions. So this is really a difficult situation. But again, with when you know this on the forehand already and not hours for the surgery, you buy some time to find out.
Yes. Okay. Thank you, Dr. Hans.
Because this is a hell of a job when you need 3 units and you need to check 1,000 donors and cross-match 1,000 donors and still find nothing, or one maybe coincidentally which is matching. You still don't have anything.
Okay, thank you. In this meeting, there is also our teachers. Would you like to give us I give a chance from her, maybe good afternoon, Professor Dr. Banundari. Good afternoon, Professor Lisyani. Maybe any opinion from professors about this topic?
Okay, thank you, Dr. Like. I'm sorry I don't open my picture. Dr. Hans, I think it's good lecture this afternoon. But we know that Indonesia is big country with many islands, and what you call the blood bank is not always high tech. It means many places in Indonesia itu have only do the cross matching and blood grouping. And what's your opinion? Because we have like maybe for funding and so on, we sometimes only do cross matching and blood grouping. Especially in, we have a difficulty, especially in autoimmune hemolytic anemia, because if we do cross-match, many times is always positive. What's opinion about this? Sometimes clinician have decision to give blood transfusion to the patient with major cross-match positive. What's your opinion, Dr. Han? Thank you.
Yeah, thank you. These are, in fact, a few very important questions. What you do see is indeed labs in hospitals. For your information, I was here in Indonesia now, I think 35 times since the last 20 years. I'm rather familiar with the situation in Sumatra and Java. And what I see is that the hospital blood establishments, so the blood transfusion services in the hospitals, are completely different from each other, and you can't always compare one hospital to the other in equipment and what is available. But they do the cross match, so they do in fact the indirect antiglobulin test. So this is their possibility besides the blood typing. So what could be in thoughts is that when you look at the region of Semarang, with already with 100 hospitals in this area already, that they send, in case of problems, they send it to a more central lab, and that could, for instance, the lab in the Dr. Karyadi hospital could play a role in doing, because you can't have, as a small center, all kind of test cells to find out what antibodies are. But in a central situation, this might be possible in a little bit easier way. So yes, you're completely right that not all hospitals can do the identification and do find the correct product, and for that you need the larger blood establishments and the blood transfusion service of the Indonesian Red Cross. That's one thing. And the other thing is, what we all know is that in autoimmune hemolytic disease patients, it's really a challenge to find compatible units when there is really need of blood. And my advice as transfusion medicine specialist, in fact, is as pathologists, clinical pathologists, is avoid transfusion, but sometimes it's not always possible. Then what I'm going to do is, in that case, is I look at how positive is this unit. So can we find the less positive units? So the 1+, or where there is a little trace in the tubes, or the 1+, in that way. And yeah, we need to be aware that we will never find a cross-match negative unit in that way. So slowly transfuse them, not in 2 hours, but in 6 hours, and avoid other things. and maybe even with giving immunoglobulins if possible, these kind of things to avoid activation of the immune system in that way to make it worse. And good observation of your patient. That's the only thing what you can do in that way. Otherwise, your patient will die because of anemia. So the less positive cross-match, I would take that.
Maybe it can be done for my cases too. Yeah, Doc.
Sorry, I didn't catch you.
Your answer.
Yeah.
It can be done to my cases too.
Yeah. Yeah, but when it's 4+, yeah, then it's real. When everything is 4+, it's almost impossible. And but in an autoimmune hemolytic disease, in the patient with autoimmune hemolytic disease is completely different, of course, from the thalassemia situation or the pre-surgery situation. It's autoimmune hemolytic disease is a problem which is coming back on a regular basis, and this is really special. We see sometimes patients with hemoglobin levels of 2 or 3 grams per deciliter, and
Yeah.
they need transfusion, but there is nothing. It's not always available, and then when the clinical situation, cardiology or pulmonology, is forcing us the less positive units I would give them in that way.
Yeah. Okay. Thank you, Dr. Hans. And I know that you have many time to visit Indonesia. Have
Yeah.
you go to Prambanan Temple?
Yeah, several times I was in Prambanan.
Ah, see.
Yeah.
The Ramayana dance?
Yes, I saw the Ramayana in September last year.
Ah, it's very interesting.
Yeah, and I was in Semarang in Dr. Karyadi Hospital, also in September last year.
Okay. Thank you,
Yeah.
Dr. Hans.
You're welcome.
Hope this year's again, yeah, Doc. Okay, if there is no question from the participant in chat room, so allowed me to resume the meeting in this afternoon.
Yeah.
Okay.
Oh, there's not a question. The Dr. Marcel.
Oh, okay. Dr. Marcel, you can ask directly. Okay.
Okay, thank you, Dr. Liko. Good afternoon, Dr. Liko, Dr. Hans. I want to ask your opinion, Dr. Hans, about our clinicians are routinely prescribed pre-medication before transfusion. It seems contradictory to me that antibody testing has given a lot of safety prior to transfusion. And how is your opinion about is it really needed to give pre-medication before
Furosemide,
transfusion?
you mean furosemide? Lasix, furosemide, so to urinate more. You mean that?
Yeah. Beside furosemide, maybe it's about acetaminophen, paracetamol. Like you know that it could be any febrile reaction after transfusion.
So
but
what is
antibody
known?
testing, I think it's enough to detect any antibody, then maybe giving something, some reaction.
Yeah,
So how is your opinion?
your answer would have given to when this was an exam, you would have given an A+ in this way for this, because I agree completely with you. It's a habit we doctors, all the doctors have from previous times. What we do know is that febrile so the febrile reactions in 1 in 200 units of transfusion will be there. So it's not needed to give that. Some what I also do know is that in plasma or in platelet transfusions, this is being done in some hospitals standard antihistaminics and even steroids in advance. Yeah, I can imagine in a leukemia patient who is having its treatment, and every 3 days this patient is having very severe chills and fever reactions that you give it. But I should not give it in routine for and before every transfusion. That's, I think, not done.
All right, Dr. Hans. Even corticosteroid is not needed actually, right?
Oh, no. But yeah, that's not needed. No.
So it has to be a change to our habits and
Yeah, but
protocols.
that's a difficult issue in medicine, in doctors. But as I think also that patient management is very important. And this is also in the way of patient management. So it's a tailor-made for the patient, tailor-made medicine, what you do. So is really, you should as doctor really consider that is this transfusion needed or not? And if yes, what should I do? So not standard always 3 units, and that's already changed in the world, that we go now and look at the personal hemoglobin levels of such a patient. Of course, I talk about in this way of a stable patient, not a bleeding patient, but it's completely not done anymore to transfuse the patient until the hemoglobin level is 12 or 13 or whatever. And also what was said when I started 40 years ago as a doctor, 1 unit is not giving a transfusion. You always give 2 or 3 units. That's standard. So these kinds should be left behind us in the more modern medicine world. So including the standard pre-medication for transfusion.
Well, all right, Dr. Hans. Maybe like what you have said, right? We can establish the type and screen protocol to determine if the transfusion is really needed, or maybe we can use the type and cross-match protocol if it has to be done right now, right?
Yeah, indeed.
All right. Understandable, Dr. Hans. Thank you for your explanation. Thank you, Dr. Lika, and good afternoon. Thank you.
Sama-sama.
Okay, thank you, Dr. Hans. It's very interesting discussion, but doesn't feel like the discussion time has over, ya, Doc. I'm
Okay.
sorry. So allowed me to resume the meeting in this afternoon. There are many erythrocyte antibody known currently. So the antibody testing is a new insight and a critical point of pre-transfusion testing, yeah. Antibody typing in the patient can detect unexpected that could react with the red blood cell, especially clinically significant antibody. As summary, the aim of antibody typing in the patients are the first is for efficacy, maybe can prevent certain transfused cell survival, and second for safety, it can be minimalized transfusion reaction, especially acute hemolytic reaction transfusion. For a lot of my mistake as moderator today, may I apologize to all participants. Good afternoon, thank you, and hopefully useful. Wassalamualaikum warahmatullahi wabarakatuh.
Have a nice day, all. Okay.
Have a
Bye-bye.
nice day to Dr. Hans.
Bye-bye. See you later.
See you later. Maybe the time I send to MC.
Okay. Bye-bye.
Thank you, Dr. Lieke and Hans Vrielink, MD, PhD, for a very interesting lecture and discussion. Finally, we arrived at the end of this guest lecture. Thank you very much for our speaker, Hans Vrielink, MD, PhD, our moderator, Dr. Lieke Rahayu Nindhita, clinical pathologist, our respected professors, attending doctors, residents, and all the audience. We would like to remind all participants to fill in the attendance link which can be accessed in the meeting chat. In this guest lecture, you are going to get a certificate without SKP. To the honorable professors, doctors, and all participants, before leaving the Zoom, we are pleased to take picture together. To Hans Vrielink, MD, PhD, Dr. Lieke Rahayu Nindhita, clinical pathologist, Dr. Dwi Ratnaningrum, clinical pathologist, consultant of infectious diseases, Dr. Nyoman Suci Widyasiti, Magister of Health, clinical pathologist, consultant of hematology and immunology, Professor Banundari Rahmawati, clinical pathologist, consultant of endocrinology and metabolism, consultant of blood bank and transfusion medicine, and Professor Dr. Lisiani Besuromo, clinical pathologist, consultant of nephrology and respiratory, consultant of clinical immunology. Please open your camera because we are going to take a picture together. On the count of 3. 1, 2, 3. Next. 1, 2, 3. Once again. 1, 2, 3. Thank you. To all participants, please kindly open your camera on. On the count of 3. 1, 2, 3. Next. 1, 2, 3. Once again. 1, 2, 3. Thank you. Ladies and gentlemen, this ends the guest lecture today. We would like to thank Hans Vrielink, MD, PhD, as the guest speaker. Furthermore, to all participants, thank you for joining us today. Hopefully, all the knowledge that has been given can enrich insight for all of us. To all committee and participants, thank you. We do really hope to be able to see you again in the next occasion. On behalf of all committee, I would like to apologize for all the inconveniences and mistakes during the event. Stay happy and healthy. Assalamualaikum warahmatullahi wabarakatuh.